Hello everyone, welcome to the case review session of MRI Hip. Let's review this case. This is the case of 16-year-old male patient who presented with pain in bilateral hip and groin region. This is the coronal PD patched sequence, and we can see both heads of the femur, they are aspherical. So there is loss of sphericity and presence of a bump or a protrusion at the junction of head and neck. And there is presence of mild joint effusion on both sides, and there is presence of marrow edema involving the acetabulum bilaterally, plus there is presence of chondromalacia in the acetabular articular cartilage. Let's see this coronal T1 weighted sequence in which there is presence of subchondral sclerosis in the acetabulum. So the T1 weighted sequence are most sensitive for demonstrating the subchondral sclerosis, and we can see presence of hypointensity deep to the articular cartilage, articular surface, and this is subchondral sclerosis. And there are presence of osteophytes at the junction of head and neck. This is the sagittal PD patches sequence, and you can see there is presence of marrow edema in the acetabulum. There is presence of chondromalacia, and there is presence of labral tear or labral degeneration as a result of the bump in the femoral head-neck junction. So this is a case of femoroacetabular impingement, CAM type. In CAM type, there is presence of a bump at the head and neck junction, and in pincer type, there is over coverage by the acetabulum. And both these types are responsible for the restricted movement in the hip joint, and as a result of that, there is presence of chondromalacia and its acetabular labral tear, and all these changes can lead to early osteoarthritis in a young patient. So this is a case of CAM type of femoroacetabular impingement. So when we talk about femoroacetabular impingement, we can classify it into three types. The pincer and CAM type are the two major types, and the third is the mixed one, which is actually the combination of pincer and CAM type, and it is the most common subtype. So what happens in the pincer type of femoroacetabular impingement, there is over coverage by the acetabulum, and it is responsible for the restricted hip joint movement. Whereas in the CAM type, there is osseous bump at the head-neck junction, and this leads to restricted hip joint movement and anterior labral tear and anterior chondral degeneration. This is a normal hip joint, and we can see there is non-restricted hip joint movement and free hip joint movement. Whereas in the pincer type of femoroacetabular impingement, there is over coverage from the anterior acetabular wall, and this hits the head-neck junction of the femur, and it often leads to chondral degeneration involving the posterior acetabulum. This is known as countercoup cartilage damage. In the CAM type of femoroacetabular impingement, there is osseous bump, and this bump hits the anterior acetabulum, and it leads to anterior labral tear and anterior chondral degeneration. So the pattern of cartilage damage is predominantly posterior in case of pincer type of FAM, and in CAM type of FAM, the cartilage damage is predominantly anterior and central. This is the normal hip joint. We can see the head of the femur is spherical, and the head-neck offset is normal, it is concave. And the acetabulum is also normal, there is no over coverage from the acetabulum side. This is the CAM type of femoroacetabular impingement. As we can see, there is osseous bump, the head-neck offset is convex, it is not concave, and this can lead to restricted hip joint movement and labral degeneration and tear involving the anterior labrum and anterior cartilage damage. So this appearance of the CAM type of femoroacetabular impingement, this looks like a pistol grip deformity. This is the normal hip joint. As we can see, this is the center of the femoral head. So what happens that the anterior acetabular wall, it traverses medial to the center of the femoral head. So it is never lateral to the center of the femoral head. Whereas the posterior wall of the acetabulum, it crosses the center of the femoral head, or it can be slightly lateral to the center of the femoral head. But in cases of pincer type of femoroacetabular impingement, the anterior wall, it comes lateral to the center of the femoral head, and in this case we can see there is cranial over coverage of the anterior wall, and this gives rise to the figure of 8 sign or crossover sign. So this is the case of pincer type of femoroacetabular impingement. In this radiograph, we can see the posterior wall is more lateral to the center of the femoral head. So in this case there is posterior over coverage by the acetabulum. This is the CAM type of femoroacetabular impingement, in which we can see there is osseous bump at the head-neck junction, and the physeal scar is predominantly horizontal. This is the done view of X-ray hip of a normal hip. We can see the alpha angle is normal and the head-neck offset is also normal. Whereas in case of CAM type of femoroacetabular impingement, there is osseous bump, and so the head-neck offset is reduced and the alpha angle is increased. So normally alpha angle is less than 55 degree. If it is more than 55 degree, we can say that there is CAM type of femoroacetabular impingement. This is the AP view of the pelvis, showing how we can take the lateral center edge angle. We draw a line which is along the long axis of pelvis and cutting across the center of the femoral head. Then we draw another line which cuts across the lateralmost part of the acetabulum, and the angle which is formed between these two lines is the lateral center edge angle, and normally it is 25 to 39 degree. If it is less than 25 degree, there is under coverage by the acetabulum, giving rise to developmental dysplasia of hip. And if it is more than 39 degree, then we can say there is over coverage by the acetabulum, giving rise to pincer type of femoroacetabular impingement. So femoroacetabular impingement can be classified into 3 types: pincer, camp, and mixed type. The mixed type is the most common one, and this situation, this pathology predominantly affects young physically active individuals, and patients generally present with slow onset of pain in bilateral hip and groin region. So this was all about femoroacetabular impingement. I hope you have enjoyed the video. Thank you.